Good morning, everybody. And sorry I can't be there in person. And I will be coughing every once in a while. I was asked to talk about how to manage side effects of WM treatments. And I think I would start by going a little bit through the different classes of therapies that are available for patients with WM. So I'll start with an overview of the most commonly used agents and regimens in the treatment of WM. These are chemotherapy regimens that are often used for Waldenstrom macroglobulinemia. I actually shaded out the ones that are no longer used, like cladribine and rituximab, or fludarabine and rituximab, or CHOP without the rituximab. The other three regimens are used very often, particularly cyclophosphamide, dexamethasone, and Rituxan, or bendamustine and Rituxan. R-CHOP is used, but it is a pretty aggressive type of chemotherapy, and it's reserved typically for patients with WM who are experiencing a transformation to a more aggressive type of lymphoma. You see here that the response rates are quite high in the 80 to 90%, and the duration of the response much longer than what you just saw for Rituxan alone. I have patients that I'm still following 10 years after starting bendamustine and rituximab, and they're doing completely fine. And in fact, their IgM is a little bit better every time I see them, despite, being 10 years from their treatment. Another class of agents that is commonly used for WM is a type of drugs called proteasome inhibitor. They are very fast in their efficacy. So they're particularly used when a reduction of the IgM, a quick reduction of the IgM is needed. We started by using bortezomib as an IV drug, and usually combined with dexamethasone and rituximab. But it was quite toxic in terms of neuropathy. The response is super high. Again, you can see here 80, 90%. The duration of the response pretty long, several years in some cases. But again, neuropathy was a big problem. And then when new drugs entered the arena, like carfilzomib or ixazomib, the neuropathy was definitely less, but other side effects appeared, like cardiac toxicity or high blood pressure. But again, these are commonly used drugs, very effective, that we still use very often. I would say that the drugs that are now a staple of WM treatment are the BTK inhibitors. BTK is a drug that BTK itself is an enzyme that mediates the survival of WM cells. And so the inhibitors basically inhibit their activity. We studied ibrutinib as the first in class of these drugs. It was relatively easy to administer. We obtained very high response rates, up to 100% in some cases. The duration of the response, again, was measured in years. The issue with these drugs was that particularly ibrutinib had a cardiac toxicity, particularly atrial fibrillation, which was unacceptable in terms of percent of patients who developed it, and therefore newer BTK inhibitors were created, which were much more sensitive for the BTK only and had a lot less off-target effect. And by doing that, the side effects were reduced. More recently, another class of BTK inhibitors called the non-covalent BTK inhibitors came on the market, particularly pirtobrutinib. As you can see here, 80 patients were treated with pirtobrutinib orally, and many of them had already failed treatment with BTK inhibitors of the first, second, and third generation. The responses were high, even in patients who had failed BTK inhibitors before. And the side effects, as you can see later, were much, much less. So these drugs are extremely promising and being tested now in combination with other agents. Another drug class called the BCL2 inhibitors are given by mouth. They basically affect the machinery of the cells that again leads to cell survival and proliferation. And the two drugs that are mostly studied are venetoclax and sonrotoclax. Venetoclax had been studied for many years in other type of lymphomas, but Dr. Castillo's study in WM revealed that it is a very active drug and relatively well tolerated. However, the duration of response possibly not ideal in patients who receive this drug as a single agent. And so again, we are exploring it in combination with other therapies. Sonrotoclax is a newer drug that is basically a more specific BCL2 inhibitor. And the data is very minimal right now, but it appears to be very efficacious and very well tolerated. Combination of venetoclax with ibrutinib actually had to be terminated because of the cardiac toxicity that we saw with that particular combination. So that's never going to be explored again. But for instance, substituting pirtobrutinib for the ibrutinib appears to be safe, and it's been explored in a clinical trial that is still ongoing at the Dana-Farber Cancer Institute. There are, of course, many novel therapies that are in development for WM. For instance, a new class of BTK degraders that have a different mechanism from the BTK inhibitors are very promising, and again, can work in patients that have failed classic BTK inhibitors. There is a drug, antibody drug conjugates that are being explored. Another class of drug called bispecific antibodies and CAR T cells. And the last two of these classes are really immunotherapy that try to engage the patient's own immune system in destroying the WM cells. So going back to each class of therapy and the side effects that they cause and how we can manage them, starting with rituximab or obinutuzumab, which is another CD20 antibody that is used sometimes. The most common side effect is infusion reaction, and that can manifest in multiple ways, from rashes to sometimes chest pressure, chest pain, chills, joint pain, low blood pressure. All of this can happen during the infusion. We know that stopping the infusion and administering steroids or Benadryl can typically control these symptoms. In some patients, though, the allergy is real and a desensitization is needed, which basically means administering the drug in a stepwise dosing so that the initial part of the infusion contains a minimal amount of the drug, and as you increase the drug concentration in the fluid, the tolerability becomes more optimal for the patient. Some patients, though, have a true allergy, and those patients should not receive further doses. And in those cases, we try to switch to the other monoclonal antibody, obinutuzumab. For some patients, none of those work and should never be used. The other thing with monoclonal antibodies is that they can lead to something called IgM flare. There's a typo there. IgM flare means that the level of IgM in the blood will increase before going down. And that can be obviously dangerous if you start with a very high level to begin with, and then you see a flare. That high level can become higher and cause hyperviscosity. So for those patients, we'd like to do plasmapheresis, which means getting rid of some of the IgM from the blood prior to administering the rituximab. Also, the other thing is that these reactions, like the infusion reaction or the rashes and all of those symptoms are much more common in patients with Waldenstrom, and probably that is due to the high level of circulating antibodies in the blood. So in my practice, I always premedicate patients with steroids, antihistaminic, and Singulair, with 2 or 3 days of premedications. And by doing that, the incidence of these side effects is reduced tremendously. And so we're typically able to get these drugs in and to reduce, to minimize really the common side effects to a minimum. Chemotherapy regimens, as I said before, R-CHOP is typically reserved for transformed disease. It can cause hair loss, and unfortunately, there's nothing we can do about that. It just happens. Hair always grows back. And the other common side effects is the white blood cells will fall with a nadir around 5 to 9 days after dosing. And for that reason, growth factors such as Neulasta or Neupogen are required after each cycle to minimize the risk of infection. We also administer acyclovir, which is an antiviral drug, as a prophylaxis to prevent herpes infection. Also, the H in CHOP is the doxorubicin. Doxorubicin can be cardiotoxic, and so cannot be administered to patients that have known heart disease. And in that case, alternatives have to be found to the doxorubicin, such as gemcitabine or others. RCD is a much better tolerated, much less cytotoxic regimen. It does cause alopecia, but it doesn't cause heart disease, and it doesn't cause any neuropathy. Rituximab bendamustine is probably my favorite regimen. Number one, because it does not cause alopecia or hair loss, although some patients experience hair thinning. It does cause low blood counts. That's particularly seen in the elderly. And it can be immune suppressive. It does have an effect on the normal immune system, particularly the T cells. And this effect on the T cells can be significant and prolonged. And so there is a risk of infection in patients receiving this drug. So again, acyclovir prophylaxis is important. But overall, it's a very well-tolerated drug, usually extremely active. And the response with this therapy can last, as I said earlier, many years. Therefore, for patients who prefer to be treated with a time-limited approach instead of being forever on a BTK inhibitor, for instance, rituximab-bendamustine is an excellent choice. The proteasome inhibitors, as I said earlier, are drugs that can cause neuropathy. So kind of tough to use them in patients who start already with peripheral neuropathy due to their WM, even though the WM-mediated neuropathy is due to the high level of IgM circulating in the blood. And with these drugs, we can obtain a reduction that is very quick on IgM level, and therefore the neuropathy can actually improve. So it should not, patients with neuropathy should not be excluded by being treated with proteasome inhibitors. However, we know IV bortezomib results in neuropathy much more frequently than sub-Q bortezomib, more frequently than carfilzomib, and again, more than ixazomib. Ixazomib is actually given orally, and overall, very easy to give, and the neuropathy very easily controllable. When there is neuropathy from these drugs, we recommend starting medications like gabapentin, also called Neurontin, or pregabalin, Lyrica. And there are alternatives, for instance, Cymbalta or anti-epileptic drugs. Most of the times we're able to control the neuropathy. Reducing the drug is also, or reducing the frequency of the drug is also a good option to reduce the neuropathy. Carfilzomib has a much lower risk of neuropathy, but it did cause in the original trials cardiomyopathy and high blood pressure. And so again, prior to giving these drugs, we want to make sure that patients are risk stratified in terms of their risk of developing cardiac toxicity. So for instance, if they've already received CHOP in the past, we have to be very careful with those patients because they have already received a cardiotoxic drug. So we can kind of tailor these drugs depending on the risk factor and their prior therapies. BTK inhibitors, as I said, these are probably at this time the most frequently used drugs. They can all cause low blood counts, so anemia, neutropenia, and thrombocytopenia. But the risk, the most worrisome risk factor is atrial fibrillation, right? So these are arrhythmias that can develop anytime during the course of being treated with a BTK inhibitor. But while ibrutinib caused between 10 and 20% of atrial fibrillation in the original trials, drugs like acalabrutinib or zanubrutinib or tirabrutinib, they have a much lower incidence of this risk. Typical of this risk is also of these drugs is also bleeding and bruising. Bruising is almost inevitable. It always happens. It's not dangerous. It might not be aesthetically pleasing, but it's not dangerous most of the times. But real bleeding can happen in 1 to 4% of the cases reported in the clinical trials. So very rare. There are sometimes other side effects like rashes or gastrointestinal symptoms, particularly diarrhea. So at the last IWM Congress about 9 months ago, we actually convened a panel of experts to try to figure out how to deal with BTK inhibitor intolerance, right? And also to define what are we calling intolerance versus real resistance, right? There are some patients that are progressing at some point. They're progressing through this treatment. And in that scenario, there is no, typically there is no sense in, switching to a different BTK inhibitor. But if we're talking about intolerance, first of all, in many cases, we're actually able to manage the side effects, right? So AFib can be managed by either giving appropriate drugs and anticoagulation. And those patients can easily continue on their BTK inhibitor. A dose reduction sometimes is all it's needed for things like joint pain or diarrhea. And sometimes we do switch from one BTK inhibitor to another. For instance, I've had patients who were on acalabrutinib with very severe joint pain, who were switched to zanubrutinib, and their joint pain disappeared. So before basically giving up on this type of drug, we know we can manage the symptoms or manage the dose or switch to another BTK inhibitor and continue on the therapy, particularly if that therapy is working well. Obviously, if the therapy is not working, then we really have to consider changing class completely, for instance, switching to venetoclax or to a proteasome inhibitor-based regimen. The other interesting thing is that patients who are on BTK inhibitor often have to stop the drug to be able, for instance, to have surgery, because we know BTK inhibitors can lead to bleeding. And so if there is a major surgery, they should be stopped for about 2 weeks before, 1 week before and 1 week after the surgery. So a 2 weeks interruption. And that interruption in up to 80% of patients can lead to, first of all, IgM rebound, which means their IgM can go up. And also in some cases, in up to 20%, there can be withdrawal symptoms. And these withdrawal symptoms are fever, chills, night sweats. So again, we try to come up with recommendation on how to manage the rebound and the withdrawal. And basically, we agreed that, for instance, if we have to switch therapy from a BTK inhibitor to another regimen because of progression or because of real intolerance, we could continue the BTK inhibitor up to a few weeks after the new therapy has started, in order to avoid the rebound and the withdrawal symptoms. So again, there are ways to get around these expected side effects of BTK inhibitor withdrawal and IgM rebound. The newer class of BTK inhibitors, like pirtobrutinib, which is a non-covalent BTK inhibitor, actually, revealed a much decreased incidence of certain side effects, particularly grade 3 or higher, which means the severe side effects. If you look at bruising, for instance, nobody had grade 3 bruising, and even atrial fibrillation, it was not seen for any grade. So there were only 2 cases, 2 patients in the 80 patients that were treated on this study who had atrial fibrillation, but they had atrial fibrillation prior to starting the drug. And then, the typical things like neutropenia and anemia, etc. Those are seen but easily reversible by using growth factor like Neupogen or Neulasta and decreasing the dose of the drug. The BCL2 inhibitors like venetoclax are characterized by causing this phenomenon called tumor lysis syndrome. What does that mean? It means that the WM cells can basically, or the lymphoma cell, I should say, can be eliminated and killed so quickly by these drugs that actually the debris from the dead cells can cause electrolyte abnormalities, renal failure, etc. And this whole phenomenon is called tumor lysis syndrome, or TLS. Interestingly, while this is very commonly seen in patients with CLL or mantle cell lymphoma, the reason for the TLS being so frequent in those type of lymphoma is that there is very high circulating tumor burden, very frequently enlarged spleen or lymph nodes, elevated LDH or electrolyte imbalances, which all predict, a high incidence of TLS. But those are rarely seen in Waldenstrom. And so patients with WM actually very rarely, if ever, develop TLS. And so avoid TLS. What we do for CLL or mantle cell lymphoma is to start with a super low dose, 20 milligrams, and then go up on a weekly basis to 50, 100, 200, and then 400 over a period of a month. For WM, this is not necessary. We can actually increase the dose or ramp up the dose in just 1 or 2 weeks. We can start at higher doses. So overall, much safer to treat patients with WM with these drugs than it is to treat patients with CLL or MCL with the same drug class. And doses up to 800 milligrams are actually very well tolerated in these patients. The sonrotoclax on the right here is the newer BCL2 inhibitor currently on clinical trials. And the most common adverse events include low counts, which is also a pretty common side effects of venetoclax, upper respiratory tract infection, diarrhea, nausea, and fatigue. But these adverse events are generally mild, and in these studies, actually no patients require discontinuation or dose reduction of the sonrotoclax due to the adverse event. And the tumor lysis syndrome, again, patients with WM have lower risk of TLS, and there were no patients who experienced severe TLS on this drug. So this is, I know, a very laundry list of classes of drugs and their related side effects, but I hope it was helpful, and I'm happy to take questions.
Prednisone. Can you use prednisone when you're going through the withdrawals of the zanbrutinib?
Yes, we do use prednisone. Indeed, that is the correct therapy. A few days of prednisone usually reverse the withdrawal syndrome.
Okay. And how about the brain fog? Like I get a little bit of brain fog when I'm on it. Does anything natural like the cognitive magnesium work?
I don't know that magnesium work. I have had actually many years ago a patient who had a couple of severe cases of brain fog to the point where he was driving the car and he needed to stop the car because for a minute he didn't even know where he was.
I had that too, yeah.
And that is extreme. Obviously, I do not see it typically, but in that particular case, I did not feel comfortable continuing. So he
Yeah.
stopped it, right?
Yeah, I lowered mine. We lowered my dosage and it seemed to
Yeah,
help.
lowering the dose is probably the right thing to do, or switching. If you're on ibrutinib, you can switch to zanubrutinib or to pirtobrutinib. Pirtobrutinib now is on the NCCN guidelines, which means that even though it's not FDA approved, it can be prescribed. And I found that patients have many fewer side effects on this drug. So it's an option for sure.
Yeah, I was on the ibrutinib and then I just switched to the zanubrutinib.
Any other questions for me?
So how does a patient go about impressing on their oncologist that their side effects, which may not be life-threatening like a rash, are significant enough to disrupt their life, and they shouldn't just be told like, just putting an ointment on it isn't an acceptable solution? How do we go about telling them like this is significant to me, even though you might say it's not a big deal to you?
Well, I always think they're significant for the patients. I think a referral to dermatology is always a good idea. I worked very much with our dermatologists. I work at a cancer center, so our dermatologists are specialized in side effects from chemo drugs or targeted therapy like ibrutinib. And I have had, patients needing to take injections to control their rash, but they were very effective. The rash disappeared, and after several months, they could stop the injections, but that was completely managed by the dermatologist. And I think it's always a good idea to consider, first of all, changing therapy. You don't. This is a great drug, but are you stuck to it? No, there are other options, right? But the second thing is a dermatologist can help you not just with putting an ointment, but it may be finding a different solution that can eliminate completely the rash. For instance, even just taking some claritin sometimes help.
Okay, well, thank you. It's just it's a unique experience maybe to me, but I suffered for a while with the rash, and I'm changing to zanubrutinib dramatically improved it from ibrutinib, but it didn't go away totally, and so I still deal with some of it, but it's it just, to me, my oncologist he didn't seem to really be concerned too much about it. It was something you just live with that. Everything else is going well, don't mess with success, as he would say.
Exactly. I mean, and I get that, when we see such if we see a really good response, it's kind of tough to say, well, this drug is working very well, but we need to stop it because you don't know if the next one is going to work as well, right? But on the other hand, you have to take each patient's side effects seriously. And as I said, I think for rash, dermatology is always our best friend.
Thank you, Dr. Paloma, very much. We really appreciate you, even though you're ill, still presenting for us.
Thank you so much. Sorry for not being there.